Good afternoon, everyone, and thanks again for joining us today for today's symposium. My talk here this afternoon will be on the clinical management of locally advanced RCC. Really, this talk will focus a little bit more on those with tumor thrombus. We know that a lot of tumors can form tumor thrombus, but kidney cancer is a lot of times the classic tumor example. Most commonly, this is seen with the clear cell histology. For this talk, I have no relevant disclosures. So kidney cancer and IVC thrombus has been well known and actually pretty well studied over the last few decades. You see it in about 10% of RCC cases at places such as Moffitt and tertiary referral centers. We see quite a high percentage of patients presenting with this compared to more community practices. The presence of tumor thrombus automatically makes it a stage 3 tumor. That's important in talking with patients and prognosis. It also is an important part because these are tumors that we know have a high risk of recurrence. Like I said earlier, the majority of these, about 80–90% per the literature, is clear cell histology. You can see them in other histologies and certainly see them in other tumors, including GU tumors such as testicular cancer, but those are exceedingly rare. Some patients do not have any signs or symptoms even when they develop thrombus. Obviously, some of these tumors and thrombuses grow slowly enough that the body sort of adapts over time. And even for those who have total occlusion of their IVC, the body has an ability to develop collaterals, which actually somewhat surprisingly can have patients not knowing that they have these tumors going on for, quite some time, even years. Some of the patients, though, will develop symptoms. The most common symptoms you see is edema is actually the most common one, and that relates back to sort of the backup of vascular flow. Usually the legs is the most common spot for that, but that's not a terribly specific symptom or sign for kidney cancer. In more advanced thrombus, especially those that reach the chest or in some cases the atrium, you can see some cardiac dysfunction as a presenting symptom. Dvts, again, relating to the stasis of the blood flow. Hematuria is one of the sort of classic examples, but it tends not to present as often as you would think, especially with how large these masses get sometimes. Additionally, with any large kidney mass, you can see perineoplastic syndromes, which includes sort of a whole list of different hematological manifestations, including fevers, night sweats, sort of weight loss. You can see abnormalities in blood cell counts and certainly in renal function. Rarely you can see things like pulmonary embolism, which would be due to primarily tumor thrombus, but also you can see pulmonary embolism due to bland thrombus, which is not the tumor part that's actually breaking off and going to the lungs, but it's some downstream or side branch affecting it that's blocking blood counts that becomes dislodged. That's actually, luckily, a pretty rare presenting symptom for these tumors. The staging for how we sort of classically talk about these tumor thrombuses is 1, 2, 3, and 4. And you can see here in the diagram that 1 is sort of just when the thrombus gets into the IVC, which obviously for tumors that are on the right side, the renal vein is much shorter, so it's much less of a length for it to get there. The ones on the left have to get quite big before they actually reach the IVC. And as you start going up the IVC towards the heart, the grade or the stage of the thrombus increases from 2 until you get to the hepatic veins, which above that point is a 3. And then when you cross the diaphragm and enter the chest, that is a 4. That's sort of how we break it down when we study patients retrospectively. Obviously, we know, and you can see from these studies here, that the higher the thrombus level, the VTT, the venous thrombus level, the worse the prognosis, unfortunately. There's been some studies looking at the types of thrombus in these types of tumors, whether they're called solid or friable. And some reports have linked friable tumors as having inferior cancer-specific survival. This doesn't have a lot of help for us in the initial phases of dealing with patients because it's really hard to discern which tumors are friable, which ones are more solid in nature. We do know for patients with very early level thrombus, or what we call level 1, or sometimes even not level 1, it's still within the renal vein, specifically on the left side, that those patients can actually have pretty good prognosis comparable to those patients who have no thrombus at all. There's other sort of factors that have been looked at, including the lymph nodes. Obviously, if patients develop metastatic disease, that dramatically impacts the prognosis for these patients. Grade, histology. Additionally, invasion into the IVC wall has been shown to be a prognostic factor and also does significantly affect how we manage these patients surgically. So when you are first dealing with a patient who has an IVC thrombus, either because they're presenting with symptoms or because you've identified this through other radiographic means when they don't have symptoms. Usually MRI and CT are employed. CT actually does a fairly good job of characterizing the thrombus. Sort of historically, it used to be recommended to get MRI in all these patients, but I think with the modern CT techniques, this is not quite as needed as before. Now, saying that, there's certainly some situations where it will be needed, especially those patients who have chronic kidney disease and therefore can't get IV contrast. But really the basis and what I use most importantly in managing these patients or determining their surgical plan is a 3-phase CT, which includes a non-con phase, corticomedullary phase, and a nephrogenic phase. And that really gives an outline not only of the mass, but more importantly of the vasculature, which in managing these patients is almost, if not more important, determining what you need to get set up for surgery if that's going to be the next step. I think a 3-phase CT is usually superior to an MRI. You can just get much better anatomical detail. You get better vascular anatomy detail, which again is helpful in that. And for some patients, most commonly those who can't get contrast in MRI is a very good option. There is sometimes when the masses or sometimes the tumors themselves are just not looking quite right, and MRI may give you more detail about the mass itself that could be helpful. There's also times when you're concerned about invasion into the IVC wall, which certainly would affect how we manage these patients surgically. And an MRI does have a little bit of superior, well, not a little bit, quite a bit more superiority in being able to make that assessment, but neither is perfect by far. Additionally, for almost all these patients, though, especially those with higher level, basically thrombus levels 2s and above, you want to get a baseline echocardiogram. That's something we would get before surgery no matter what. I think it's important to know, especially if a patient already has underlying cardiac comorbidities, that their heart, the blood flow back to the heart is not being impeded. That would sort of determine the urgency of intervention for patients. Additionally, patients who don't have good heart function, they may not be good candidates for surgery because in order to take out these thrombuses, we're usually talking about clamping the IVC. And depending on how obstructing that thrombus is, that can be a shock to the system, especially to the heart. It's also important, obviously, in this day and age to complete the staging, sorry, not in this day and age, in all day and ages, to complete the staging for these patients. We need to know where else the tumor could be, because that can certainly affect how we manage these patients, and talk a little bit later, even more so, I think in the future, it'll affect it. But really, it starts with a good CT scan head to toe, including the head, especially if they have symptoms. One of the things that I see most commonly in patients being referred is getting PET scans for these patients. Really, there's no good role for a PET scan in this case. Really, PET scans in kidney cancer really don't have a role. And to be honest, they sort of don't help us too often because, one, they tend not to be as sensitive and specific as many people think they are. And two, they lack any of the anatomical detail that would actually help us in determining surgical management for the patient. So often, they're pretty much a useless test in this capacity. So medically, it's important to try and, identify if these patients have symptoms and try and manage those symptoms best as possible. Ultimately, some of the symptoms won't resolve until the tumor or the thrombus comes out. Like I mentioned before, having a stable cardiac exam is a critical part of that. Obviously, this is a big surgery. I don't think that's a surprise to anyone. And you need to be as optimized cardiovascularly as possible to tolerate a big procedure like this. This will also help determine some of the urgency and possible non-surgical options. Talk about more in a minute here. For those patients with higher level thrombus, even if they have no cardiac symptoms, you have to sort of get an idea if their heart can tolerate such a major operation, including if you're going to have to do coronary bypass, do cardiac bypass for stopping the flow of blood, and if their heart can tolerate something like that. Obviously, it includes some routine blood work, CBC, CMP, PT-INR, make sure those are all in check. For those patients who have hematuria, they do need a cystoscopy. Obviously, the vast majority of these cases, the hematuria is related to the kidney mass, and sometimes you can get a good sense of that based on their imaging. If they actually have a small primary tumor with a thrombus, which sometimes you see, you really want to think that other sources could be coming from the hematuria, namely bladder cancer. So I think it's important to do a cystoscopy on these patients with hematuria before you take them to surgery, because it could certainly affect your surgery or add another layer of complexity if they're found to have a second primary tumor. For most patients, when they first present, they do not need to be on anticoagulation, especially if they're not having any symptoms. The only exceptions to that would be for patients with PEs, obviously, or those with DVTs. I think especially for those with PEs, but also those for DVTs, one of the common things that I hear from community providers or people who aren't familiar caring with these patients is about they sort of have the desire to want to put an IVC filter in there to try and stop pulmonary embolism from developing. I think with rare exception, that's not a good idea. One is we know, at least in the historical literature, the risk of them having a PE from these thrombuses is actually very, very low. Two, and I think more importantly, if you're considering surgery, having an IVC filter there makes surgery much more difficult. In the rare cases where we do need to do it, it's important we get it done, that the IR person knows that surgery is going to be going forward so that they place the filter in pretty much the most optimal spot. Now that spot sort of depends on the level of the thrombus, but again, that should be a decision that's sort of ideally made by the surgical team with the IR team, because it can certainly have some consequences to the ability to perform adequate surgery. If a patient needs anticoagulation, that's fine. You can put them on it. It doesn't preclude surgery. Depending on how they present, especially with a P or something, there may be some need to, make sure they stabilize and delay surgery for a few weeks, but this isn't something that would prevent surgery, at least in the short term. If they have other things that make them predisposed to blood clotting, if they're wheelchair bound or have other mobility issues, it's questionable about whether some prophylactic things like Lovenox or aspirin or any of those help. For the most part, I'd say there's really no literature to support it. Can it hurt it? It really depends if they're presenting with hematuria or something like that. For those who already have hematuria, you put them on blood thinners. Well, you're going to run into some more problems, not surprisingly. There's really no contraindications for these patients. A lot of times patients and providers ask questions about what they can and can't do. Obviously, I wouldn't recommend going dirt biking or rock climbing for that weekend, but for the most part, they can travel accordingly. If they're not taking long plane trips or something like that, I don't think there's any limitations to their daily activities for the most part. So another common question I get is about the need or the desire to embolize the kidney before. I think the general sort of consensus is this is not something we do, at least here, and I think around the country at a lot of places that do a lot of these surgeries that they do very often. There are exceptions to this. If patients have uncontrolled bleeding, then really this is a good idea because you got to stabilize them. You can't get them to the OR if they're bleeding acutely. If you anticipate that it's very difficult to get control of the kidney, and most specifically the renal artery, then it can have a time and place. But again, I think that should be a decision that's made by the treating surgeon before you do that, because there is some consequences, again, to embolization. Where the location of embolization takes place within the artery can affect the surgical approach as to where you have to take the artery. If IR goes in and puts a bunch of coils very proximal to the artery, then you're not going to be able to go across there with the surgical stapler, and you're going to have a hard time tying that off just because of the mass effect from the coils. So that's another important thing. Additionally, patients after an embolization like this develop a lot of symptoms typically. And this is sort of the post-embolization syndrome. And about 90% of patients will have it. It can be quite painful for patients, and most patients need to be in an inpatient setting after this. For those few patients that we do plan to embolize, we usually coordinate it accordingly so that they either get the embolization done in the morning or the next day they're off to surgery, because we don't want to have a lot of time for the inflammation to build up. Plus, again, patients can have a lot of symptoms from this, and you want to try and get in there and get the kidney out as soon as possible. Additionally, there hasn't been any studies that show that doing this provides an oncological benefit. I think some earlier papers are looking at this, hope to sort of, by cutting off the blood flow, they could pull down the thrombus a little bit, but there's been no papers to show that that's been the case. So I think for the most part, we try and avoid this actually, because it tends to add another layer of complexity to these patients who are already pretty complex. So one of the newer things that I think will be emerging, it's certainly not standard of care at this point, but it has been looked about in the past, is neoadjuvant systemic therapy. This has been looked at with some of the older agents like the tyrosine kinase inhibitors. The results were not terribly great. There appeared to be some benefit as far as decreasing the tumor burden and specifically the height of the thrombus. We do know as the higher the thrombus goes up, the surgical complexity goes up quite a bit. But for the most part, this never found a solid footing in managing these patients. Also because these agents can have their own set of side effects, which can, again, add further complexity. And without a large percentage of the patients having benefit, the risk-benefit ratio really wasn't there. Obviously, over the last couple of years with the advent of immunotherapy and the checkpoint inhibitors, there tends to be more enthusiasm for this. There's certainly been case reports and studies out there in small subsets of patients that have shown sometimes very dramatic responses. I think as more of those treatments, and especially those combination treatments, are showing better and better initial responses, I think it's something we're going to have to consider more and more often in these patients, because traditionally we know that even with surgery, especially for higher level thrombuses, patients just have such a high risk of recurrence. We're trying to do more upfront to prevent that. And if it can facilitate surgery and decrease complications, then I think that's a no-brainer. This happens to be one of those cases you can see on the left here. This is the patient's thrombus. It was about 8 centimeters in diameter going across the IVC, and it was up to the hepatic vein. This patient who I'd seen had some questionable lung lesions, wasn't anything definitive, but they had actually already started on immunotherapy before I saw them, and they were tolerating it quite well. So we had a thorough discussion about the risks and benefits of surgery up front, and elected to proceed with him going through his first couple cycles, about 4 cycles of treatment. And as you can see on the right, it did have a response. We didn't see this dramatic drop in the level of the IVC, but you can see the IVC itself changed, became a little more cystic, not quite as solid, and certainly the diameter across the IVC decreased. That has some importance because we know that tumors that are really wide and bulky in the IVC have a higher risk of IVC wall invasion, which can make surgery a little more difficult. Luckily for this patient, we were able to get them to surgery, and they did well. And as of right now, have no evidence of disease. Those little lung lesions haven't grown or changed at all. So the question is, were they ever metastatic disease? Well, we may not find out, but as long as everything continues to not grow, I think the patient has a good prognosis. Again, I think in the future, we'll probably see more and more of these patients, and we'll have to address this in more studies. So surgery, again, if patients need bypass, the risk goes up a lot. And usually for patients with level 3 and under, we're not talking about bypass. Depending on the level 3, there may be a need for venous bypass, which is certainly preferential to our cardiopulmonary bypass. For level 4 ones, the ones that are in the chest, and certainly the ones in the atrium, there's really no way to get around that. That's going to be a major operation. So I think having a really upfront discussion with the patient and their ability to tolerate that procedure is needed. Radical nephrectomy with tumor thrombectomy, has been associated with some major perioperative morbidity. About 70% of patients in some series will have significant complications. And there's a real chance of mortality in these patients, especially for the higher level ones. When you look at the retrospective series, it's anywhere between 3 and 16%, but obviously a lot of that has to do with the surgical approach. Are you going to need bypass, along with the patient's comorbidities? For level 3 and 4, it's critical that you get involvement with the hepatobiliary service, and certainly for level 4, the cardiac service, because you're going to need their assistance. And so this is where we coordinate with not only our providers here at Moffitt, but also those down at Tampa General for those who need bypass. For level 2 through 4, all of them should have a transesophageal echocardiogram done before surgery. Should have put that up earlier too, to try and really delineate where the level is, especially if there's questionable as it's getting close to the hepatic veins. Ideally, you want to have this in the OR for those level tumors too, because as you manipulate the tumor, you start taking vessels, things can change. You want to make sure that it doesn't change your surgical approach. Sometimes for these patients, depending on how much you have to narrow the IVC, you may have to put patches and grafts, and depending on your level of comfort for that, that may be something where you have a vascular surgeon assist you with that. I think most of the teams, hepatobiliary and even some of us here, are comfortable with doing that to some capacity, but you should get a pretty good sense of what that chance is based on their preoperative imaging. For some patients who have total obstruction of the IVC, and like I said, the body is sort of adapted to getting blood back to the heart without the IVC, you can actually ligate it with, not having too much in the way of consequences. Again, if you think you're going to do that, it's important you don't take a bunch of the collaterals as you're getting in there, because you want to facilitate as much blood flow back to the heart as possible. As far as lymph node dissection in these patients, it's really debatable. It's similar to the localized disease. There hasn't been a clear benefit to patients. So for the vast majority of these patients, they don't undergo lymph node dissection, at least for myself. Now, granted, if a patient had a single lymph node that was in, close to where it would be resected or anywhere in the abdomen that we think needed to come out, that's certainly something we could do, but the benefit for that, it hasn't been clearly defined. with that, I will end it here and take your questions. Thank you.